Good afternoon, everyone. On behalf of the International Association of Chiefs of Police and with support from the John D. and Catherine T. MacArthur Foundation, I'm happy to welcome you to today's webinar, Law Enforcement's Path to Improving Public Safety, Partnering with Local Behavioral Health Agencies. My name is Karen Moline, and I'm a project manager at the IACP for the Safety and Justice Challenge, an initiative funded by the MacArthur Foundation to encourage the creation of just and effective local justice systems. Before we get started, I'd like to quickly go over a few logistical items about today's webinar. First of all, while we scheduled 90 minutes for the webinar, we want to be respectful of busy schedules, so the presentation is limited to 50 minutes with the remainder of the time for Q&A. The webinar is being recorded for future playback. A link to the recording will be available soon on the Safety and Justice Challenge page of IACP's website. This link will be emailed to those who registered for the webinar and posted on the Safety and Justice Challenge Exchange. We will also have links on the page to the PowerPoint slides, speaker information, and a transcript of the webinar. Today's webinar is being audiocast via the speakers on your computer, but if you don't have speakers or would prefer to use your phone, use the number provided in your registration confirmation email or on the event tab located on the top right-hand side of the screen. There are many people joining us today, so we automatically muted the phones of participants who called in to reduce background noise. If you are using your phone but are not a presenter, please keep your phone muted. If you typed in *6 to unmute your phone, please retype it to remute your phone. If you need technical assistance during the webinar, please email our IT staff at itteam@theiacp.org. If you'd like to submit a question for the speakers at any time during the webinar, use the chat feature and direct your question to organizers. Our intention is to leave all questions for the end of the presentation so that anyone who needs to hop off can see the entire presentation and then catch the Q&A later when they have time. But go ahead and submit the questions at any time and we'll queue them up. For those of you participating in today's webinar as a group, please take a minute to help us get a good count of attendees. Using the chat feature, type the name of the person registered and then enter the number of additional people in the room with you and send that to organizer. We really appreciate it. And finally, at the conclusion of today's webinar, you'll be asked to take a brief evaluation survey about today's presentation. The information you provide will help us to plan and improve future webinars, and it's very much appreciated. On to the webinar. As the strategic ally for the Safety and Justice Challenge, one of our goals is to assist participating law enforcement agencies to identify and develop promising strategies for safely reducing arrests and incarceration. Accordingly, our work in pre-arrest diversion, which reduces both arrests and incarceration, has become a cornerstone of our Safety and Justice Challenge work. Today's discussion is the second in our pre-arrest diversion webinar series, which is intended to help law enforcement, other criminal justice stakeholders, and community leaders take the first steps in establishing or enhancing a program that will fit the needs of their community. There is a recording on our website of the first webinar in case you missed it. As a brief recap, presenters provided an overview of pre-arrest or pre-booking diversion, as it's also sometimes called, discussed the 5 models of pre-arrest diversion currently in practice as identified by the Center for Health and Justice at TASC, and listed questions agencies should ask themselves before starting their own initiatives to ensure that they choose the model that addresses the issues they're facing. That webinar also introduced the Police Treatment and Community Collaborative, or PTAC Collaborative, an alliance designed to provide national vision, leadership, voice, and action to pre-arrest diversion. PTAC is a network of practitioners in criminal justice, behavioral health, research, advocacy, and public policy, whose mission it is to strategically expand community behavioral health and social service options available through law enforcement-led diversion. Anyone who is interested in having a voice in pre-arrest diversion, whether by working to create a guide of best practices, collaborating on core measures to evaluate programs, advocating for members of the community, or educating the field or policymakers about the benefits of pre-arrest diversion, is invited to join the PTAC Collaborative and can contact me for more information. At this time, I'd like to thank the MacArthur Foundation for supporting this webinar, as well as our ongoing work in pre-arrest diversion with the PTAC Collaborative. The topic for today's webinar is building partnerships between law enforcement and behavioral health. But before we move to pre-arrest diversion, I'd like to talk specifically about building these partnerships to address the issue of mental illness, and more specifically, police response to mentally ill individuals. We all know that police officers are often the first people to respond to other people with mental health disorders and are asked to face situations they may not have the training to face. A 2015 Washington Post study reported that 1/4 of those killed in officer-involved shootings were experiencing an emotional crisis. The Treatment Advocacy Center found that people with severe mental illnesses are 16 times more likely to be killed by police than other civilians. And in a series of listening sessions conducted last summer by IACP of law enforcement leaders in 8 locations around the country, one of the reoccurring and consistent concerns raised was the role of public safety officials in addressing public health issues, including police interactions with persons affected by mental illness. IACP responded to these and other concerns by launching the One Mind campaign. The goal of the One Mind campaign is to increase the number of successful outcomes for interactions between law enforcement and persons affected by mental illness. Law enforcement agencies are asked to join the campaign and pledge to implement 4 promising practices within a 12 to 36-month period. To partner with community health professionals, to put a policy in place, train 100% of sworn staff on mental health first aid, and provide crisis intervention team training to a minimum of 20% of sworn staff, as well as selected non-sworn staff. The benefit to agencies of implementing these practices are similar to the benefits of most pre-arrest diversion programs: increased community and officer safety, enhanced community police relations, better use of criminal justice system resources, and the creation of innovative and sustainable partnerships between behavioral health and police professionals. As of early this week, and it changes all the time, 140 agencies had taken the pledge to join the campaign, and you can see the names of those agencies right on the One Mind webpage. For information on how your agency can take the pledge, go to the One Mind campaign webpage. There's also information for small agencies on resources for partnering with mental health service providers. By the way, I wanted to give a shout out to the listeners on the webinar from the Memphis Police Department, which is where the CIT model originated. We're happy to have you with us today. And now I'd like to quickly introduce today's panelists, but also let you know that more information about them is available on our website. I've been asked to let you know how to open your chat box. Just click on the chat box if you need to ask a question or enter the names of more people who are with you. And I think there's a message to everyone on the chat box from our moderator. So our first panelist is Raymond V. Tamisi, who has over 40 years of experience managing treatment, intervention, and prevention services. For 25 of those years, he was president and CEO of Gosnold on Cape Cod, a provider of inpatient and outpatient behavioral health services that merited national recognition. He is currently the president and founder of the Gosnold Innovation Center, focusing on the development of innovative approaches for addiction treatment, prevention, and medical integration. Mr. Tamisi has a Bachelor of Arts degree in economics and a Master of Education with a concentration in counseling and healthcare administration. Sergeant Michael Simino is a 19-year veteran of the Falmouth Police Department. He has worked as a patrol officer and detective and was promoted to the rank of sergeant in 2014. He currently is a patrol supervisor on the midnight shift. In addition to his supervisory duties, Sergeant Simino has been the alcohol enforcement agent for the town for the past 6 years. He also has assisted Gosnold on Cape Cod staff with weekly follow-up visits to all non-fatal drug overdoses that occurred in the town of Falmouth for the last 2 years. And Officer Tyler Narbone is a 4-year veteran of the Falmouth Police Department, currently assigned to the midnight shift. In addition to his regular duties, Officer Narbone participates in follow-up mental health visits with staff from the Falmouth Human Services Department. This service reaches out to individuals experiencing a mental health crisis or who are known to the community from a previous mental health commitment. Officer Narbone is a member of FPD's Crisis Intervention Team. Welcome to all of you, and thank you for being here today. Ray, we're passing control of the slides over to you now.
All right, thank you, Karen, and thank you all for attending today. We hope this will be a good learning opportunity for you as we share our experience and our perspective on the current state of mental health and particularly the opioid crisis. So, let me see. I've got the slides. There you go. Okay. Oh, I gotta go back. So these are some of the things we want to cover today. We're gonna talk a bit about the opioid crisis. I have some information that may sort of fill in areas that I know you know a lot about this. I have some information that will expand your base of knowledge, but particularly how this crisis has led to collaborations in our community. We're going to talk about the collaboration with a police department particularly, but just as a sort of an overview, the entire community has come together around this issue in a very important way, either as a direct intervener as we are, or as a supporter as we have engaged the business sector, the educational sector, and town policymakers in creating a pretty substantial array of both services of direct treatment and also a pretty robust prevention program. So we're going to talk also about how this particular initiative has changed the community and has enhanced the whole concept of community policing. And then we'll talk a little bit about what we've learned, some of the outcomes that we've been able to achieve, and a little bit more about the collaboration. This is one collaboration amongst 29 that Gosnold has with police departments both on and off Cape Cod, mostly in southeastern Massachusetts and Cape Cod. So it started very small about 2 years ago and has grown quite rapidly, and we're very pleased with how this direction is taken. So that's what we're going to try to do. Let's hope we get to that place. This is stuff you know just by background. The involvement of both mental health and substance use disorders in criminal justice system. You can see that probably 2 out of every 3 encounters with an offender is a person who is engaged either in with some kind of mental health problem. So it's only really to point out the relationship, not the stuff you already know, but also the relationship of these numbers to the general population. So it's a massive problem in our society. Also, this is a little piece on how we have become the opioid consuming country of the world. By far the most opioids consumed than any other country. We actually consume 100% of the Vicodin that's produced, and you can see that this has primarily been the primary thing that's responsible for the crisis that we find ourselves in. And it is not a crisis, as you know, that it just occurred in the last 3 or 4 years. This is a little bit of a dated piece, but the significant thing here is that this started really, as you know, with prescribed opioids, and although it wasn't deemed a crisis by general society in 2003, we can see that there were as many heroin overdose deaths in 2013 as there were from opioid pain, prescribed pain medications in 2003. So we have a crisis of 20 years in the making. It's not going to go away in a year and a half. And of course, in the last several years, particularly last year, right, with the onset of particularly fentanyl, which is now implicated in, what would you say, Michael? At least, what, 75% of the overdose?
Yeah, 55 to 70, I mean 50 to 75%.
Yeah, and particularly, I think the Northeast has been particularly hit by the fentanyl influx. Okay, let's just move this slide along. Can't move it, Ryan. There we go. And here's another illustrative slide that basically tells you if you make it, they will come. So as opioid prescriptions began to grow and sales grew, so too did overdose deaths and the demand and expectation around treatment. So this is very much a parallel process. This is a slide that a lot of folks haven't seen. It's particularly striking. This is all-cause mortality between the age of 45 and 54. The striking thing about this, compared to all these other countries, mostly European countries, Canada, Australia, Sweden, Germany, France, the U.S., for white 45 to 54-year-old, the mortality rate is going up. It's all due to primarily overdoses. You can see this is taking the changes from 2000 to 2015 by age group. Every age group has seen an increase, and these are deaths from poisonings, which are overdoses, suicide, liver disease, and cirrhosis, which are alcohol-related disorders. Very, very troubling trend. This is also breaks it down a little bit by particular condition. You can see the poisonings are overdose, the suicides, the liver disease, all going up, and lung cancer as a sort of comparative condition has gone down, and certainly attention has been paid to that for many, many more years than we paid much attention to addiction. So we have a problem that goes well beyond overdose, but goes to the very fabric of our society and is affecting, as you know, every element in many, many different ways. It's really no different on Cape Cod. Well, we're speaking to you from Falmouth, Massachusetts, which is a town in the upper Cape of Cape Cod, and you can see that Falmouth has been pretty significantly affected, along with Barnstable, which is the largest community on the Cape. Cape Cod has actually got the highest number of overdose deaths per capita than any other county, Barnstable County, which is Cape Cod, than any other county in Massachusetts. So for lots of different reasons, and I'm not even sure I know every reason, but this area of Cape Cod has been, this area of Massachusetts has been particularly struck. So that's sort of the background and the backdrop of what we're facing in the country, and certainly this area is no different. You're familiar with these, what we call intercept points. What we're going to be talking about today is really intercept point 1, pre-arrest. You know, there's a lot of work being done in drug courts and reentry programs, community support, and other kinds of diversion activities. We're going to sort of focus on what we call intercept point 1. Basically, the goal is to try to get people to treatment, and certainly with the ulterior motive of diverting people from more criminal activities. So you might want to say a little bit about this, Michael, how this partnership began. I mean, frankly, it was overdose deaths that really precipitated even thinking about doing this, right?
As we saw the numbers grow in 2013 into 14, we knew the game had to change. So early 2015, I started going out to do home visits to people that had overdosed. Just to give you a background, I never imagined in a million years I'd be doing something like this. Everyone, I have a history. I was in the detective unit. I was on the drug unit. I was on the special response team. Banged in my share of doors. Now instead of doing that type of work, we're knocking on doors and having a conversation with people. I want to say in the 2 years we've been doing it, over 2 years now, we've never been turned away. Been invited into people's homes, talking to the overdose victim themselves or a family member. People have been very responsive to us. And I want to say in the very beginning, I'd pull into the driveway and people would have the fight or flight look. They didn't know whether to run, whether to stay. As soon as we started talking to them and let them know why we were there, everything changed. We're not a magic bullet. We go there and we offer them help. What they take from us is up to them. I've gone to the point of putting people in the back of my unmarked cruiser and and delivering right to the detox center that's located in our town. And just to back up, I go out plainclothes with a recovery manager from Gosnold, and that's how we do the visits. We try not to, we go very unassuming, and don't try to scare people off. And like I said, in 2 years, we've had great luck. Like I said, whether they go right with us that day, a lot of times we do an intake over the phone right from their house. The recovery manager will put them in contact with Gosnold, the facility, get them on the phone together, and they do an intake. And they might get in later on that afternoon or the next morning, but we've had pretty good success in getting people in. If they don't go in at that point, the recovery manager stays in contact with them. He's like my recovery hound dog. He keeps contact with these people. He gets them on the phone. He sees where they're at, and sometimes 2-3 weeks down the road, someone will call them and you can get them in. Other people, choose, to do outpatient therapy, inpatient therapy. They'll say I'm going to meetings, NA meetings, AA meetings, and that's good enough for them, and we respect that. But about 75% of people take some sort of treatment from us. So I think it's been very effective.
Thanks, Michael. So I want to go back just a bit and tell you how this began. It began actually innocently in a way. We were watching a broadcast on the New England Cable News, and we learned that day from the interviews they were doing with the folks down at the Yarmouth Police Department that Yarmouth was doing Yarmouth PD was going out and doing exactly what you were saying, Michael, to go out and try to engage with non-fatal overdose victims. And we were watching that, and we said, gee, this is an area where we're pretty familiar with how to talk to these folks. Maybe we ought to call the department and see if we can go with them, and maybe we can apply some of our expertise in engaging with these individuals and help them, help reach out and convince them to go to treatment. And what happens, we went down, we talked to the Yarmouth Police Department. They said, gee, this is a great idea. Let's think about, what we want to do here. And so I said, well, give me a couple of days to think this through, and I'll get back to you. And because there was no funding to do it, we got in our car and we were driving back from Yarmouth, and the person I was with, a young woman in this picture, went on her phone and said, oh my God. I said, what happened? She said, I just went on the Yarmouth Facebook page, and they're announcing that, thank you, Gosnold, for partnering with us on this new collaboration. And we had no idea really at that point, but that was enough to give birth to the program. And because most of our services are in Falmouth, we got a call the next day from the chief, Michael, and said, hey, what the heck? What about us? And that's what, a year and a half, 2 years ago, and here we are with 29 departments. And I think it was around the same time, isn't it, Tyler, that you began to be involved with the mental health entity down here on the Cape?
That's correct. I just wanted to say thank you for joining, and good morning and afternoon to anybody out there. I started doing it about 2 years ago, kind of following suit of Sergeant Semino's kind of model. I do cold follow-ups with a clinician from Falmouth Human Services. We go out and we follow up with these individuals that we dealt with, either it's on a previous shift. We try to go out once a week, maybe twice in a month, depending on what's going on in the call volume. We go do these cold follow-ups. Marks, who's the clinician, sometimes knows these individuals, and we'll just go in a good light. I do the same thing. I go out in plain clothes, unmarked cruiser, and the response has been, positive. I mean, you'll still get these, negative responses here and there, and that's just at first. Once they realize why you're there, the response is amazing, and it's almost paying it forward to the officers that are on duty, because they see us in a good light, which is I've seen work for me multiple times. Usually we'll sit down with them, talk with them. Most of the time what I've seen is they are connected, at least around here, but what we do too, and Mark will do, is he'll do a follow-up call with the Department of Mental Health and let their clinician know what's going on, because sometimes they're unaware that the police were actually dealing with them, whether they're not taking their medications, whether it's, you know, an opiate or a substance abuse, an alcoholic, you know, problem. And then sometimes it's just regular life that's just hitting them. You know, they broke up with their girlfriend, they experienced a traumatic event, whether it was a family death, and it's just enough to set them off on a, you know, whatever episode they have. You know, I was approached by the chief 2 years ago. We had an influx of calls. He realized, and I mean, our department realized that, you know, we were going to these calls and we weren't solving the problem. We were just there to kind of put a Band-Aid on it, if you will. You know, we have a Falmouth hospital located in our community, so we'd drop them off there and then we'd be on our way. Next day, they're on the road again. You're like, well, I just dropped them off. What's going on here? You know, he was just, you know, fighting with me, and now I have to, you know, go to the same call again. Well, this isn't working. So that's when the chief approached me. We went out with Mark and just started talking with these individuals. And I mean, we're still dealing with an influx of calls. We are a summer community, so we get a lot of people here, whether it's, you know, for the summertime, whether it's for treatment. So we are still dealing with it. But what I've seen, at least right now, is it's in a positive light. They're seeing the cops kind of as a friend and not as an enemy, which has been paying it, like I said, paying it forward for the officers out there. We are, you know, curtailing it. I have seen where individuals that we've gone out multiple times for, we're not going out there anymore. You know, we might deal with them once a month or something, where we used to deal with them on a weekly basis or multiple times a week. So it's been successful, and hopefully it will continue being successful.
And when did you do CIT training?
I did it about 6 months ago. They did it down here on the Cape. It was a Taunton group that sponsored it, and it was a great program. It helps with de-escalation techniques. Kind of, you don't want to play into their model is basically what they're trying to teach us. You don't want to, you know, joke around, oh no, you don't see this individual, oh no, you know, that person's not there, and kind of make fun of them. Or go in there, you know, kind of like our type A personality, and, you know, start yelling and demanding things, because that's just, they're already up on a, you know, a ledge, if you will, and now you just don't need them to jump. You need to de-escalate the situation, calm them down, talk to them. You know, they might see somebody, like I just dealt with somebody that they saw a police officer on a flagpole. Well, I don't see the police officer on the flagpole. I believe you believe that there's a police officer on the flagpole. It just de-escalates the situation. It calms them down a little bit. They're already nervous that they see us there. And from what I've seen, a lot of mental health individuals, they're not violent, they're just scared. And yeah, for now, it's been working great, and the training was, I mean, priceless. It's really helped me out there in the field, and I think a lot of officers should start taking it.
So one of the key elements, of course, of this is, you know, having a relationship or a collaborative relationship with a treatment or behavioral health organization. I think, Karen, I think you have a poll question about that, which you may want to put up.
Yeah, we're going to launch that poll right now. So the question is, in your jurisdiction, is there an existing partnership between law enforcement and a behavioral health provider?
Putting results up.
Okay, the poll is closed.
Okay, that's great. That's great. Well, that's a great start, huh?
Absolutely.
Yeah.
So 61% say that they have an existing partnership, 8% say no, and 31% say they're unsure if they do or not.
Okay. So we've started to touch on the direct engagement part of this project, but we've also done some things to try to share resources. And as there have been many departments that have had difficulty getting naloxone, and we actually worked out a deal with a manufacturer of one of these products. This is one of the early things that we did down here to provide 1,500 doses of the injectable form of naloxone to a number of departments here on the Cape and off Cape. So it's not just out there in the field. It's also sharing resources, expertise, and ideas about how to make things better. So, and then Michael and our intervention folks. So we got some interest in the area newspapers about this. So these things actually have, they're good for the department, they're good for the agency, but they're also good for the general public to read about how different areas of interest in the community are pulling together to try to address this problem. And I think it helps to reduce some of the stigma attached to it too.
Absolutely.
Don't you think so? So those are, and we've talked a little bit about how the program works. We get involved as a recovery specialist at the time that you actually, like Michael, you're maintaining a log or a record of the people who are the overdose victims.
Yeah, on a weekly basis, I run the log of all overdoses for that week, and go out with that list with the recovery manager.
Yeah, and then our target is to try to get to them as quickly as, right?
We've actually gotten to them while they're still in the hospital, believe it or not, while they're being there treated for the overdose. We've actually, searched them out at the hospital when those circumstances came up. But otherwise, yes, I think, the recovery manager has stated, it's Gosnell's feeling, the sooner we get to someone, the better luck we have getting them in.
Yeah.
Sometimes it might not be for a week, it might be 2-3 days, it might be a week, but the bottom line is we're getting out there. And like I said, the success rate has been pretty good. Most people, they don't want to continue this cycle. They just can't kick it themselves, and they need the extra help.
So are you seeing, is it fair to say that the greater time from the event to the engagement, the less likely you are to get the person to say yes?
A lot of times they've slipped back into their, into their what they were doing. If we can get to them a lot sooner, because it's still real fresh in their mind, the incident. They might have, many of them have been Narcan multiple times. Maybe not thankful at the time they were Narcan. Most of them aren't. They're a little angry that, that their high was ruined, unfortunately. But I think, I said that, the sooner we get there, the better luck we have.
So what is so how available then is the intervention specialist to you?
He's made himself very available to us. I work the overnight shift. The supervisors on the day shift and the evening shift have his card. They can call him directly. He answers the phone.
So you're not the only person who connects.
No, I don't have. No. And I've given everybody his information so they can reach out to him. So if we can get somebody sooner than later,
So that all shortens the time, right?
Correct.
And then I know you've told a couple of accounts early on when you went out with Lenny. That's right. Lenny is the guy. Yeah, Lenny. And you go out in uniform or in plain clothes?
Plain clothes.
Okay. So, but typically, when somebody sees you coming, because they know you, they expect that you're there really not to offer them a carrot, right?
Yeah. But my old story is, instead of banging on doors, we knock on doors now. No. The way I policed for the last 19 years, folks, I'm a pretty fair guy, and I know a lot of people that are overdosing. And then if I don't know them, Lenny will know them. They've probably already gone through Gosnell, believe it or not, and they just relapsed. So and we were both of us are born and raised in the town we're working in, so we know a lot of people. So if I don't know them, he usually knows them, If neither one of us know them, our personalities take over, and people respond to us. I think this is a good time to mention, if you're thinking about doing this program, personalities are huge when choosing someone to work with, the mentally ill or, someone who is overdosed. The police academy will be Tackleberry. You don't want, someone going in there with, there's a lot of bravado in our job. You kind of have to check that at the door and kind of, be sympathetic and empathetic to these people and try to work with them. It's huge. So, like I said, when choosing somebody to do this type of work, you really want someone who can drop the tough guy attitude or the tough girl attitude, and work with these people. And any given shift, any given night, we're a doctor, we're a nurse, we're a Dr. Phil, we're a marriage counselor, or whoever. So I think a lot of people say we don't have the the training to do work like this, but I think we do. I think my experience counts for a lot. And I'll interject when I feel it's it's something useful. I don't just spit off the mouth. I speak when I think I have something valuable to add, and I think the recovery manager and myself work great off each other. And like I said, people do respond to us. And we just the other day we were just checking on somebody who was scheduled to go to detox, and we wanted to check with him right before he left. And he had a bag packed at the door. Very thankful. Thank me. Thank Lenny for helping him get in, and hopefully he'll have some success.
So, as you've done this over time, Tyler and Michael, has the culture in the community changed? I mean, when I say the culture in the community, I mean the folks who are impaired, the mentally ill or the addicted population. Is there a sense that sort of news travels in those circles?
Yep.
And so, is this a situation where the internal conversation amongst the individuals are sort of like, you guys are pretty good guys, and so if you're coming to investigate something, it's okay to not be frightened by it?
I think a lot of people that open the door now are expecting us. After an overdose episode, they know someone's going to probably come in and knock on the door. And
so they're expecting.
A lot of them are expecting us now. A lot of them they talk to each other, and their community, and they know we're coming usually. And like I said, open arms pretty much every time we go.
So same thing, Tyler?
Same thing, or I'll speak with the mother or the father who's just overwhelmed with what's going on. We sit down and talk with them, let them know, hey, these are the resources available. If you want to call us, we're anytime. It just puts us in a good light. I mean, we're not there just to take them away. We're there to actually help them, and we do more than just put handcuffs on somebody and bring them to the hospital. Or have to use a tool on their belt. We're there to actually make sure they're okay.
I mean, the opiate side is the same thing. With meeting with parents and loved ones, even if the overdose victim is not home, we sit down and talk to the parents, the family members. They're tired. They just have their wits' end. I had one mother say, "I'd rather have my son home. I'd rather have my son home than kick him out and him die on the street." But just exhausted parents, exhausted family members who don't know where to turn, and we can give them options of what to do.
So some of those things have led to the development of other services that we provide. So we do a family support group, and once a week here, it's open to any family that's struggling. So it's sort of like one thing leveraged another and leads to another. I would expect that there may be folks out there who are either doing this or thinking about doing it, but are concerned that they don't necessarily have an easy sort of referral track. Like how do you get, you got to get somebody in. If somebody says, yes, I'll go, then
hey, Ray,
the objective, yeah.
Ray, that leads me to a question. So did you guys have a previous relationship, or how did your relationship actually get started? How were they able to refer to you, or how did you start your partnership with law enforcement?
Well, we've had a long. I mean, our organization's been around since the early '70s. So the first point of contact had to do really with decriminalization of public intoxication in this state, and where officers were not arresting, but sort of restraining people in what they call protective custody here, and then they had the option of going to a detox. And I can say that that was a mandated activity, and early on the relationship between the treatment provider, who was very anxious to try to help people, and the police department was just suddenly engaged in activity that didn't involve apprehension and arrest. It was like, what are we doing here? And so that was foisted on us, and we sort of worked from there. But I'd say in the beginning the relationship was a little bit crusty because the right? I mean,
well, when I first started, Gosnold, the facility in our town, was probably 95, 96% alcoholics.
Right.
And now it's flip-flopped
right.
to 96, 97, 98% opiate abusers.
Right.
And there's a few percentage of alcoholics, so it's definitely changed. But whenever we do place someone in protective custody, we always, it's our policy, we call Gosnold, let them know who we have in custody, and if they're requesting treatment or refuse treatment, either one, we let them know. And sometimes beds are available, sometimes they're not. And if there's no beds available, they'll stay with us until their time is over, and then they.
So, I mean, we just really saw, we've done trainings over the years with departments, and I mean, we just really saw that we're both, invested in this community and the health of this community and the safety of this community. So there's really a natural affinity, and I think the separation that has been, that you sometimes see in towns and communities is something that here, I think we've done a really good job of overcoming, because it truly is a partnership. So we've been doing it a long time. We've talked a little bit about this. I did want to ask you a little bit more. We know that you're both going not in uniform, right?
Correct.
Yeah, there are some departments where they do go in uniform. It's really sort of a decision that is made individually, and I believe almost everybody around here goes in unmarked vehicles because you don't want to draw attention to the sort of the peekers, the people peeking out the window. I wonder if you say a little bit more about selection, officer selection, and sort of the mixing of roles, because now what we're talking about is you in a role of helping people, but you as police officer, or you're also arresting people.
I mean, yeah, when we go out there, we never sacrifice officer safety. That's the one thing I will say. No matter what you're doing, don't sacrifice officer safety for anything. When we go out, if you have to handle a call, do your job. But if you can take a step back and the scene's safe, absolutely. Just take the time and talk to the individual. See what you can do. If you can find someone in the community that's, like we have Family Human Services that can go ahead and help, get in contact with them. It's a quick email, quick phone call, and then get them set on the right path. So.
And a lot of times, if someone that is overdosed, maybe has warrants, they're wanted, we don't want to kind of have them the program to be distrusted. So, I'll just back off of that person. Maybe have patrol go in, make an arrest, and once they're in the system, we can work with them from there. But we don't want I don't want to be knocking on people's doors and saying you're under arrest, but I want to get you help too. So we let the patrol force handle that. And that way they're off the street and they can be dealt with and hopefully get the services they need.
Can you say one more thing about why are you the right guys to do this as opposed to somebody else?
Say to start.
I think it's
personality.
And give a shout out to my mom and dad. Good upbringing. I think I bring a lot to the table. I bring empathy, sympathy, street smarts, common sense. It's just, you have chicken soup of an officer. You just have to have a lot of different ingredients to make it work. It's not every guy or girl is cut out for it. And, I'm thankful that I have what, inside me. Like I said, banged in my share of doors. And but now you're just kind of putting on a different hat. Still go out every night and do the other stuff, put the handcuffs on people and everything else. But this is totally different. On Wednesday mornings, I put on a different hat. We go out. And like Tyler said, never compromise officer safety. I'm still armed, have handcuffs on. We're still ready to act, and
So you really got to,
If anything comes up.
You got to have to and want to do it. I mean, you just don't throw anybody in there, because if they don't want to do it, you're going to see it right away. Whether they go on follow-ups or they don't do follow-ups.
Or the way they treat people.
Exactly.
You need the right, like I said, you need the right person with a good, strong personality who, and yeah, there's, a little ribbing around the station, but I think we're the ones that they call, after the fun and jokes are over, we're the ones they call if they have a problem with someone, on the mental health side or the drug side, we're the ones that they reach out to. So I think we provide a good service to the department.
That's great. So we talked a little bit about the CIT model. When you went through that training, were you engaged also with people who were mental health patients or families? Or?
We spoke with individuals that were, and they kind of actually reversed the roles. So how they reversed the roles was they actually put us on headsets, and we had voices speaking in our head, and kind of they were going through like what would be a normal intake with questions, but we'd be distracted. We'd have different functions we had to do, and it was to train the mind that you got other things going on while you're still trying to cope with life. And you kind of got put in their perspective, and you realize, okay, this is a problem. This is why they're acting this way. So that was great that the training actually put it kind of in practice, that aspect. It really got me to see that, they can't control it. And it really did help.
That's good. So role reversal.
Yep, role reversal.
Yeah, walking in the shoes.
Yep.
So what have we done? So in the we have some data here on the overdose program, and so this is not just Falmouth. These numbers, these are all the departments we're working with, and I think we might want to say a little bit about, because I think the numbers, the percentage of the, so there's total victims, and then the number that were actually reached. So we've we've reached about half of the people who are victims. So you might want to say a little bit about the, why aren't we reaching 95%?
Being a so-called recovery community, I mean, Gosnold's a sought-after place to go for recovery. So we get a lot of people from out of town that come into our town. And so, after they overdose, we do take their cell phone at the time of overdose and either get permission to access it, or we have to get a search warrant for it to search their phone to see if we can find any intel on a dealer and so forth. So a lot of people being out of town, we have trouble kind of connecting with them afterwards. We've had, we have several sober houses in town where, sober living residences where people live, but after they overdose, they're usually kicked out of those houses. We can go to those houses and maybe try to track the person down. People living there might know where they went to, but, and also the recovery manager that works with me does approximately 29 other towns in close proximity to Falmouth. So if someone from out of town in one of those towns overdoses in Falmouth, when he does the checks in the other towns, he can search for them. We're trying to tighten the number up, trying to get more information from the person when they do overdose, whether it's a family member's contact information, another address where they can be reached. But we want to really tighten that number up of people we contacted.
I think that's also been true in the other towns on the Cape, where there are folks who just don't have permanent domiciles. They're moving around a lot, and you just can't get a hold of them.
It's summer community too. I mean, you get a lot of people coming from different towns that are just enjoying it. The beaches around here, or just enjoying summer in general, and then they go back home and they're.
Is the same? Is it the same with the mental health patient?
Yeah. The substance abuse, like Sergeant Simino just said, it's a recovery community. So mental health kind of goes hand in hand, whether they're, the mental health individual is trying to cope with their issues with alcohol, drugs, they try to self-medicate, so they come here for assistance. Now we're dealing with them. We have individuals that come here on timeshare, they're enjoying the beach, they have an episode, we're dealing with them. But then it's hard for us to follow up.
Right.
Luckily, Mark with Human Services is in contact with DMH, which if they're in the state, sometimes we can get a hold of them. Sometimes we can't, which is, it's hard. But we try to get a hold of other law enforcement agencies where they are or maybe residing, see if they're aware of the individual. Maybe they can do a follow-up.
The good news here is that of the people who we were able to reach, more than 75% of them said yes, they would do treatment, and probably half of those went to a detox. The others either to an outpatient or intensive outpatient program or some other service. To some degree, I think, doesn't that speak to this whole business about that people think you really can't do anything until somebody's ready? But in effect, these individuals are not so much ready because they're not calling. They're not calling someplace and saying, I need treatment. They're sort of unmotivated, and then you show up and you work your magic, and suddenly sort of the unmotivated becomes motivated.
But taking it back, I think some of these people have never been offered help. They didn't know this existed, the program existed. And to see the look on their face, I mean, especially in the beginning. Now it's becoming more of the norm. But in the beginning, people could not believe we were there, cold calling, offering help. They couldn't fathom it. So, and I've visited plenty of people that I've arrested or been involved in the arrest, so they know who I am. Like I said, the way I policed for the last several years, I'm decent to people. I'm a fair guy, and they know where they stand with me. I try not to judge. It's hard in this profession not to judge people, but I put that aside and we deal with it. As long as they're cordial to me, I get goes the same way. I get cordial to them. So, but no, it's been rewarding so far.
So kind of, to some extent, dispelling the myth that you really can't help anyone until they've decided they want help. But in fact, this is actually proving the opposite almost.
Yeah. I would just kind of give
so
a
Ray,
push
I'm going to interrupt one more time because time is getting short, and so I have an important question because this is one of the things that we said that we were going to ask on the webinar. How can law enforcement agencies or jurisdictions, how do they reach out to their community behavioral health providers and either ask to partner or suggest partnerships?
You just got to know your community. Start, looking, like we have Falmouth Human Services, which is a town-run organization. We have Falmouth Hospital, which is in our community. So we were able to partner with them, which is really good. But you're going to have to do maybe some homework, figure out who's out there for a clinician, maybe the hospital, see who they use for for the mental health calls. I know for Falmouth Hospital, the Department of Mental Health, they have a subcontractor known as Bay Cove. They go out and they actually do the assessment at the hospital with these individuals once we drop them off. So you can get in contact with the hospital that you would typically bring somebody, whether it's a car crash or opiate or mental health issues, and see who they have, and that might be a good starting point. They might be able to guide you in the right direction. Or get a hold of any state-run organization, get a hold of their mental health services. They, I'm sure, will know of people in the town or the community.
Oh, thank you. That was great. And a follow-up question, because I know this is a big issue. For behavioral health providers who want to reach out to the mentally ill or those who are addicted and know that law enforcement might have a handle on who these people are, how do they reach out to partner with law enforcement if that's what they want to do?
We reached out to Human Services, so we kind of took the initiative. It's kind of hard. So there's state law in Massachusetts that it's called HIPAA. It's confidentiality. They can't kind of approach us, hey, this individual needs, who are you dealing with? And then we have, guidelines that we have to follow. But if the organization or the department wants to go out and reach out to these organizations, let them know, hey, listen, we got an influx of calls. We like to partner with, whoever, and go out so you guys are aware of who we're dealing with, how frequently we were dealing with them, and see if you can curtail the problem. Because, like I said, we were dealing with individuals 2-3 times a week for a call, and now we may be dealing with them once a month, or if ever, once they got the services they needed, if they were even aware of the services that were provided.
I think from the provider side, what we recognized and started to do some years ago is that we could either do what we do and wait for people to call, and normally they would call when they were in crisis, or we could start thinking outside of the sort of four walls of a treatment organization and begin essentially to go to where the patients were. And so to that end, we reached out to police departments, we reached out to schools. We're now in 24, 25 schools. We reached out to medical practices, all in an effort to sort of get to where the patients are, where the affected people are, as opposed to sort of waiting for the person to get to a point where they're in such desperation that they can make that call, because a lot of people can't make that call. So I think, the collaboration with community partners, I think, is terribly important, both from the intervention side, but also from the prevention and early identification side. I mean, some of the things that we're doing in medical practices are really working with individuals who have not even been identified as a mental health patient or an addiction patient, but have signs that indicate that they're at greater risk. So I think for the behavioral health organizations on the call, it's really that opening up those conversations with your hospitals, emergency departments, police departments, schools, and other practitioners and invested people in the community, because we can't really stay in the little sort of small place of the treatment center, the outpatient clinic, and wait for somebody to get sick enough to call. And I think that's one of the ways that we can perhaps do better interventions. So.
Yeah, correct. I mean, the one thing myself and Sergeant Semino know is communication. That's the number one thing. You really got to communicate. We communicate within the department now, letting us be aware of what's going on with individuals, whether they dealt with them with a mental health crisis or an overdose. And then we go ahead and we let everyone know, like I'll let everyone know from the Family Human Services side. I'll let them know right away what's going on, so that way they can go out and curtail the problem as soon as possible.
And there's nothing wrong with a local health agency reaching out to their local police department and say, let's start a conversation, and let's see what we can do, and start pounding out a roadmap to get something like this started.
So I think, we talked a little bit about stigma, and particularly as this community, I think, we've seen a significant reduction in how the general population here thinks about these conditions, and the fact that they are illnesses and not just sort of socially reprehensible conditions that are screwing things up for everybody else. What about the impact on other officers in the department? You said a couple of things about that.
Well, so with the influx of administering Narcan, I mean that's a lot. I think a lot to expect out of a person. You're bringing someone. I mean, technically, a lot of these people are dead. So, and our officers are bringing it back, and no one's thinking twice about it. The after effects maybe to the officer, what goes through their head, and a lot of the times it's people they've dealt with previously, probably in a bad way, and now they're performing life-saving measures on the same person. I mean, it's tough to it's a lot to ask a person to do. We've done it. We've taken the bull by the horns. I mean, we carry it in our cruisers. We have it readily available. If going into an overdose, we carry it with us. We have it, ready to go. A lot of times it's multiple doses. So it is wearing. Whether it's just like almost going to a fatal car accident or a bad child abuse case, a bad domestic. This is as real as it gets. Bringing somebody back from near death, if not death. So it is a little taxing. I mean, but the officers are coming around. They know it's our reality now. Back when it first started, I mean, the past few years have taken off. The epidemic has just grabbed us and we'll let go. A lot of these officers kind of were maybe negative about it a little bit, but I say anybody's a day away or from knowing someone being affected by this, whether it's a neighbor, a loved one, whoever. There's people that we work with that have had family members that have been stricken, by mental illness and addiction. So, you never know who you're dealing with, but for the most part, everybody has stepped up, answered the call, and we try to take care of each other, talk to each other, and debrief as best as possible when one of these incidents occurs.
Great. So going forward, of course, from the treatment side, we want to know. Okay, it's great that somebody got into detox, but from our perspective, are they still engaged in treatment? And what is that? So does this lead to sort of sustained remission, if you will? About 10% of those folks that we've reached up to this point have had another overdose. We're going to look at that a little bit more closely. And then, of course, the bigger picture here is sort of the revolving door. It's great if you get somebody into a detox or you get them into the mental health hospital. They're there for 3, 4, 5, 6, 7 days. You could see them again, you know. So this really speaks to how these are emergency interventions. They're not sufficient to sort of solve the whole problem. It's really one little segment of the issue. The other is, I think, you know, Tyler, you mentioned about the pay it forward benefit for this, and then the sort of overarching question is, how does community policing make the community safer, and is there a perception in the community that these services that you're engaged in is making this place a better place to live?
I've gotten great feedback from our program, from the opiate program. You know, whether it's from social media, people respond. You know, there's still going to be negative comments out there, negative people out there, but a lot of people respect the work we're doing. They know the work we're doing, and like I said, in this town, it's, you know, 35,000 people. We've been hit hard by the epidemic. So if you don't know someone, like I said, if you don't know someone directly affected by it, your days are numbered. It's hit that widespread. And so I think people, you know, definitely have responded in a positive way for the work we're doing.
On the behavioral health side, I mean, they're in the community, so it's a community problem. So to work with the community to give these people help it's been very beneficial. It's not just a police department issue. It's definitely the whole community as a whole needs to, you know, step in and help out, and that's what Falmouth's been doing. That's why we're with Human Services. That's why we're with, you know, the hospital. We're really trying to, you know, give them help that they need, because, I mean, just bringing them to the hospital, that's just a quick fix, and then they're back out again. That's not, you know, helping them out any. So
I might add also that this collaboration has led to other types of collaboration. I was just thinking, and you know, we have something that'll be going on here in the next few days. It's a collaboration on a prevention, sort of drug abuse prevention initiative that involves the Gosnold, the police department, the sheriff's department, and the fire department, and the Cape Cod Baseball League, which is almost really like AAA players. We have a baseball league down here in the summertime with really great baseball, and that's a community event, a family event, and I think it elevates the role of both provider and law enforcement in terms of you know, sort of being engaged at a different level with the community. So really good results here. And it's a very progressive community. They're into a lot of things, and they're always looking to try to help. So if you're thinking about doing this, yep.
I'm back.
Karen, go ahead.
We've gone over the presentation time by a lot. But I've been hesitant to interrupt because this is great. This is fascinating. But we've had a lot of really, really good questions come in. So I want to give you a couple minutes. Oh, you want to get to them?
Well, I think this slide speaks for itself. We've talked a good deal about this, and these are just some things that folks would want to give consideration to if they're thinking about doing this. So let's go to those questions.
Okay, let's go to the questions. We did have one follow-up poll, and for the 8% who said that they're not collaborating with behavioral health, and the 31% who were unsure, let's go ahead and launch that second poll. The question is, if you don't have a relationship, do you have the resources for the relationship? In your jurisdiction, are there sufficient behavioral health provider resources to undertake a partnership? So here are the questions, and I'm reading them in tiny, tiny print. Did your community have a mobile crisis service or mobile crisis services from the local behavioral health provider prior to this partnership? And if so, does it remain, and how do they play a part?
Say that again, Karen.
Did your community have mobile crisis services, or I guess CRT, from the local behavioral provider prior to the partnership? And if so, does it remain, and how did they play a part?
Not on the addiction side, but I think on the mental health side, right?
Yep. They were doing it previously before, but they were unaware of who we were dealing with and how frequently we were dealing with them. So for us, for the partnership, it was great for them to realize, hey, I just saw this, let's say John Smith, yesterday, he didn't say anything about interacting with the police. Now he's aware he can go in and talk to the person. Because a lot of times with these individuals, they don't want to go back to a hospital. They're scared because they go back to the hospital, they're locked up, it is what it is. So they're scared and they're kind of apprehensive on, being straightforward with these individuals. So now, me to talk to Mark and say, listen, we just went to see him last night, 2 days later, he's having these issues. We can go out there and curtail that problem, hopefully curtail that problem, and give him the services he needs. And, the clinician is, he knows more going into the situation than he would have previously.
Okay.
Thank you. Okay, the next question is, does law enforcement reach out to others in the community other than behavioral health, such as local chamber groups or other groups supporting neighborhoods?
We just started an additional program. Actually, Tal and I got plucked for it also.
Yep.
With, I guess, the do-gooders of the department. But a new homeless initiative. But we don't have an overwhelming homeless population in Falmouth. But we do have kind of the hidden homeless sleeping in their cars and so forth. And a lot of times that is a result of either drug abuse or mental illness. So it kind of goes hand in hand. So we've started a group that has, there's local entities involved, with a housing entity, a human services entity, a mental health piece, and we just started meeting. A couple social workers from Falmouth Hospital are also on board, and we're trying to get probation involved at court to keep track of these people and get them the services they need when we do find them. And a lot of times it comes from referrals from on the patrol side. I found some people directly, Tyler's found people directly, other officers will email us and let us know, or contact us immediately and let us know that someone's out there homeless and we get them help. So, again, the society's changing, the world's changing, and a few years ago I never imagined us doing all this, all these programs, but they seem to be working pretty well, and I think we're just going to, continue forward.
So I know I've done a number of talks in front of chamber groups and Rotary and Kiwanis. Have you?
I have not, but the police chief has. And the police chief actually, I think, is on the board of our local chamber of commerce.
Okay.
So he's directly connected to them and continually, apprizes them of what's going on in town. And he also does quarterly reports to the town, which is televised, and it's at town hall for our local board of selectmen, and lets them know about everything going on in the department, to include these programs, to include our stats and where we're at with the programs.
Okay, got anything else, Karen?
Oh, yeah. You talked about how the relationship between law enforcement and behavioral health developed and evolved, but what about your local prosecutor? Has he or she tried to take over, own, or otherwise subvert the program? And I'm not sure we have any prosecutors registered for the webinar, so feel free to be frank.
No, we've heard nothing from a local prosecutor. I know the local judge, he's a new judge, that just started to sit at our court, and he's well in favor of this type of program. He's well in favor of us letting the court know when probationers overdose. They want to be involved in it. He's at a previous court. He started a drug court, and I think he wants interested in doing the same thing here in our local jurisdiction. But like I said, with the new program with the homeless, we're trying to get probation on board. But the prosecutor has, we've heard nothing from them.
We've worked with the district attorney's office here for many, many years. In fact, initiated the first drug court in this area back in 2003, and the DA was on board with that from the beginning. they run a number of programs out of the district attorney's office, including, there are also alternative options for juvenile offenders and for young adult offenders. And the district attorney's office has been very active in supporting programs and services across Cape Cod. So they have been not an unfriendly partner in every sense of the word, very supportive.
I've seen it on the behavioral health side. We've been partnered with the DA also. What we do here is if we have to take out charges for a mental health call, usually what we do is we have a form that's an in-house form. We fill that out and we attach that to our arrest packet, and that goes over to court. So that lets the court know this individual has a mental health issue, and they can, handle it appropriately there too. So we found that to be beneficial too. But we haven't really spoken with them too much, but they are also inundated with what's going on.
In our local court, they're very well versed in the game. I mean, they process all our Section 35, which is alcohol and drug committals through the local court here. It's right located in our town, Falmouth. We have a local district court, so they are well entrenched in the epidemic also with us. They process multiple, probably Section 35s a day, family members or police officers requesting a committal for a person that's, refused to get help, or and now to back up a little bit, we're starting where if someone overdoses twice in 6 months in our jurisdiction, I personally will, reach out to them and see if they will get treatment on their own. If they do not get treatment on their own, I will file for a committal for that person to get picked up and go to treatment.
Thanks. Okay. How many communities are part of these multidisciplinary teams? I think you said 29.
Well, and we're working with 29 departments. There are 15 towns on Cape Cod. We're working with 14 of those towns exclusively, and then with another 15 or 20 departments on the other side of the Cape Cod Canal. Many of those are collaboratives, so that because we can't do it all, with other behavioral health providers and other community organizations. So right now, 29 in all.
Okay. Are you dealing with compassion fatigue from either or both groups? Is another question.
Compassion fatigue, yeah.
Compassion fatigue.
Well, I haven't really run out of gas yet. You still got me. I'm still going strong. It's been 2+ years. I got about 10 years left, and I think I get some gas in the tank. So I don't see the opiate epidemic in our town. I don't see an end game to it right now. I see other officers, maybe firefighters too, who have dealt with, with the same person that has overdosed multiple times. That I think the compassion does start to wear a little bit. I just try to instill that, the person in active addiction doesn't think like you or I. Their brain is technically broken. They're not thinking straight. They're going to do anything to get the drug. They're going to do anything to get away from us, the police. They're just, their brain's in crisis. So you really have to slow yourself down. Don't take it personally. They might, whatever they say to you, they're going to lie to you. They're going to probably insult you. But when it comes down to it, it's someone's loved one. It could be, it could be your son, could be your daughter, could be a relative, could be a neighbor. You really have to, really think about that. So I think, I'm not going to speak for Tyler, but I still have, a lot of compassion left for the people, that are, addicted to people we deal with generally on the street.
I mean, for the behavioral health side, it's if we deal with the same individual over and over again, it's almost like a red flag. Okay, what was working wasn't working. So why don't we figure this out? So we usually get in contact with some other organization, whether it's DMH, Department of Mental Health, or Mark will get a hold of someone else and maybe even section the individual and get them to some treatment, because it's just what we were doing wasn't working. So gassed, fatigued, I'm not right now. Maybe in 30 years, I don't know.
Well, I've been doing this for over 40 years, so I'm like, But what we do with we have a number of other related type of services that we do with recovery specialists. So we meet almost every other week. We go over tough cases. We talk about how people are handling the multiple kinds of crises that they work with, and there's a lot of mutual support that we have. We give our folks access to those kinds of supports, and I don't see their enthusiasm flagging either. And we also have the opportunity more than you do to see folks that are in recovery who have been through these programs, who are now functioning. They're doing success stories do a great deal to bolster your enthusiasm for this.
Yeah, that must be a shot in the arm right there. That was actually sent by a behavioral health specialist, and I think that he was wondering about law enforcement and I guess commitment and how long people can go when that's not exactly what they're trained for, and how they feel about doing it. So that's great.
I mean, we were taught is basically, sorry to cut you off.
No,
we were
go
taught
ahead.
it's like if I were to handle anyone's family member, how would you want your family member dealt with? If it was your brother, sister, mother, or father, and that's how I go out there when I interact with these individuals. So I'm not gassed, not tired or anything like that. It is what it is. It's my job. I'm going to go in there. I'm going to give 100% every day.
Thank you. We're going to get into the weeds for a second. Are there any partners involved in the program that help individuals navigate health insurance eligibility for the treatment that matches their needs?
Well, we would do that if we don't burden our recovery specialist with that. His job is to just make the connection to treatment. If that person who comes to treatment then doesn't have health insurance, we have the capacity in this state to enroll them to get the thing going when they reach the point of treatment. But relative to ability to pay for services, this is a what we call a payer blind service. It's not the responsibility of the specialist to worry about whether a guy can pay or has insurance or doesn't have insurance. I mean, Massachusetts is essentially a universal coverage state, so it's very easy to get folks enrolled. I know that's, we were the precursor to the ACA with Romney Care, so I don't know that, we have a luxury in that area that many other states don't have.
Thank you. Now, I'm going to ask this question, but I already know that Officer Narbone is on the crisis intervention team, but this question did come in. Is there a crisis intervention team in your area? If so, is that implemented in your efforts? And so we've already heard that you have a crisis intervention team. Do most of the other police departments on Cape Cod have crisis intervention teams, and who provides your training?
So we have NAMI, which is a great, which sounds like you're familiar with.
National Association
National Alliance.
Yep.
Yes.
National Alliance, right.
And so they're the one that held this CCIT training, which is just like kind of instead of saying crisis intervention team, their model for down here was community crisis intervention team, which is held by the Taunton group, which I stated earlier. I know Yarmouth, I believe, Dennis, Barnstable, here in Falmouth, a lot more. I went with Providencetown, a few others out on the lower Cape, Chatham. So they're slowly starting to come in and get this training, and it's kind of new on Cape because it was only being held in certain locations like Taunton and I believe in northern Massachusetts. But now it's starting to reach down here, which the departments are getting on board. Myself and Sergeant Semino right now, like we just stated, we got the homeless program going. So now that he's sitting down on the board, I'm sitting down on the board, and now we got individuals with housing. We can kind of all communicate. This is where communication comes into play. this individual might have a substance abuse problem, but is also mentally ill. We can talk amongst each other, make sure they don't fall in the crack. They might have a housing and a mental health issue. We can talk to each other. We have all the specialists there, so that kind of helps out, and we're starting to see that kind of take a role.
So, and we have a regional group, a county-wide group that sort of speaks for all 15 towns on the Cape, and that the objective that group has, the task force, is to have CIT training in every department on the Cape in the next year or two, I think.
Thank you. So just to follow up on the last poll, 23% said that they didn't have the resources to reach out to behavioral health, or they didn't have the behavioral health resources for these kinds of partnerships. And our intention is to work with other strategic allies in the Safety and Justice Challenge to work on this, and because I know that there are innovation sites, innovation fund sites that we've talked to about this, and try to come up with solutions, you know, even if they're remote, you know, solutions like video or however you can possibly, you know, solve this problem of being in a rural community, smaller communities, and not having those kinds of resources for law enforcement, behavioral health resources. So we're hoping to address this in a later webinar, talk about it at the next cross-site meeting or something like that for those of you who are in the Safety and Justice Challenge. Those are all the questions that came in from webinar attendees. So I think that brings the webinar to a close. Please remember, I want to say please remember, those of you who are leaving us, to complete your evaluation surveys on your way out. And I want to thank our speakers, Ray Tomasi, Sergeant Michael Simino, and Officer Tyler Narbone for their time and expertise. Thank you so much, you guys. The MacArthur Foundation for their support, and everyone in the audience for joining us today. We hope that you enjoyed today's presentation and will join us for future webinars. For the IACP, this is Karen Moline. Have a good afternoon.